Good afternoon, everyone, and welcome to today's webinar. Please know that this webinar is being recorded. This webinar is the fourth in a series associated with a cooperative agreement titled Improving Access to Care, Using Community Health Workers to Improve Linkage and Retention in HIV Care. It's funded through the Minority AIDS Initiative Fund and the Health Resources and Services Administration. This cooperative agreement spans from 2016 to 2019, and it's administered by HRSA HIV/AIDS Bureau in the Division of Community HIV/AIDS Programs. Thanks so much for attending. At this time, I'd like to give you a few bits of technical information. We're asking all attendees of the webinar to ask their questions using the Q&A function, which you can see here by the thick red arrow. If for some reason the Q&A icon isn't working for you, you can also use the chat box. And I have support today from my colleague Rebecca. She'll be tracking your questions, and we'll answer as many as possible at the end of the presentation. So at this time, I'd like to turn it over to Dr. Linda Sprague-Martinez.
Thank you, Allison. My name is Linda Sprague-Martinez, and I'm the Principal Investigator of this initiative. I'm also an Associate Professor and Chair of the Macro Practice Department at Boston University School of Social Work, and I'm affiliated with the Center for Innovation in Social Work and Health. On the next slide, you can see today's agenda. As Allison noted earlier, this webinar is the fourth in a series. You can view the other webinars on the Center for Innovation in Social Work and Health website and at Target HIV. We will share the links at the end of the presentation. Our objectives for today are as follows: to provide a brief overview of this community health worker project and the goals of the project goals and activities, to describe the roles, skills, and qualities of a community health worker and their origin, to apply the roles, skills, and qualities of community health workers in the field, describe lessons learned from implementing a community health worker program across 10 project sites, and to provide a question and answer period for the audience to ask their questions. And now I'll turn it back over to Allison. Thanks,
Linda. So this is just a brief overview of the Community Health Worker Initiative that this webinar is part of. As mentioned before, the cooperative agreement spans from 2016 to 2019. And this initiative is funded by the Minority AIDS Initiative Fund of the Secretary of Health and Human Services. Here at Boston University, we are funded as the Technical Assistance and Evaluation Center for the initiative. So the four goals of this initiative are to increase the use of community health workers in order to strengthen the healthcare workforce and improve access to care and health outcomes for racial and ethnic minorities with HIV. Assist Ryan White HIV/AIDS program-funded medical provider sites with the support they need to integrate community health workers into their multidisciplinary care teams. Develop tools, materials, and resources to facilitate implementation and the use of community health workers, and to evaluate the effectiveness of community health workers on linkage and retention in care for people with HIV, and assess the effectiveness of TA activities. As the funded TA/ETC for this cooperative agreement, the team at the Center for Innovation in Social Work and Health employed a competitive process to select the 10 sites for this initiative. And this map shows the 10 funded Ryan White HIV/AIDS provider sites that worked on the project. The 10 sites are about 70% urban and 30% rural, and they're all focused in areas that serve high proportion of racial and ethnic minorities living with HIV. And as you can see, these sites overlap well with the priority areas for the new initiative, Ending the Epidemic. This is a brief overview of the initiative structure. We provided technical assistance and training to each of the 10 sub-award sites, as well as established a multi-site evaluation that each of the sites participated in. The multi-site evaluation used an implementation science framework in order to evaluate effectiveness of CHW programs. To supplement and augment the experience for technical assistance and training, we structured what we called learning sessions, which were modified learning collaboratives. And the learning sessions were intended to take what was provided in technical assistance and training and really help sites apply that to their specific agencies as their implementation went along. So at this point, we want to share the definition of a community health worker because we feel that it's really important for all of us to be grounded in the same definition of the workforce and the profession. And this definition comes from a 2014 policy statement from the CHW section of the American Public Health Association. And I'm just going to go ahead and read it because it's so important. A CHW is a frontline public health worker who is a trusted member of and/or has an unusually close understanding of the community served. This trusting relationship enables the CHW to serve as a liaison, link, intermediary between health social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. A CHW also builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. So keep this definition in mind as you hear the rest of the webinar. At this point, we want to share some general background, especially for those of you attending who maybe aren't that familiar with community health workers' roles, skills, and qualities. So the proposed roles, skills, and qualities that we'll talk about today are really intended to form the range of CHW practice. They're not necessarily intended to define the practice of any individual community health worker or organization, but rather it represents the scope of practice potentially for CHW roles and skills, as well as an essential set of qualities. So national roles, skills, and qualities have been established through a project called the CHW Core Consensus Project, which started in 2014. We'll talk a little bit more about that in a moment. And the purpose of this is really to try to build some consensus about the CHW scope of practice, as well as competencies. And building consensus around these items is really an asset to the field and important in the contribution towards workforce development. And right now in the CHW workforce, states have really taken the lead on defining roles and competencies and also in certification, but the national consensus is somewhat weaker. So the idea of these national roles, skills, and qualities is to try to continue to build the workforce. So the process really started in 1998 with a study called the National Community Health Advisor Study. And this was the first national look at CHW core roles, skills, and qualities. In 2014, the CHW Core Consensus Project was created and really took materials from this 1998 survey, as well as data from 6 states and one of the oldest community health worker workforces, community health representatives in tribal nations. They began to review the materials at a workshop of the American Public Health Association meeting, CHW section. And about a year later, the project released a report that listed roles, skills, and qualities of community health workers. If you're interested in more information about the C3 project, we're happy to provide that. So what are the CHW roles that came out of this project? CHW roles are also known as the CHW Scope of Practice, and the roles help to define and set the boundaries of the work of any profession. So the roles that you see here that have been outlined from the C3 report might not be all formally required in a specific work setting, but they're all often at play in some combination. So I want to make a quick note about role number 3, which says coordinating care, system navigation, and case management. So we all know for Ryan White funded programs, case management is a specific role that's nearly always separate from the CHW scope of practice. And challenges with CHW roles often relate to the case management role and how it is or isn't different. It's important to remember that as an old but new workforce, community health workers cover many different job titles across many different types of agencies and social conditions. So case management as a CHW role might apply to other chronic medical conditions like diabetes, cancer, cardiovascular disease, for which there's not the same infrastructure as Ryan White. So CHWs might have case management in their scope of practice if they work in a community organization or with other chronic health conditions. CHW skills are important as contributors to the competency of CHWs. And CHW skills also establish important parameters for the field and inform decisions about the training and education of community health workers. So as you can see here, some of the important skills of CHWs are around outreach, capacity building, communication, and service coordination and navigation. CHW qualities are important because they can help to inform the qualities that characterize effective CHWs. When CHWs are recruited, agreement on qualities can help inform a job description, the interviewing process, the recruiting process, and employer decisions. And these qualities came from existing portrayals of qualities in the National Community Health Advisor Study, 1998, as well as from New York City. And hopefully you'll see in these qualities a reflection of the definition of community health worker. So how can we apply these roles, skills, and qualities? So the roles can be used to help develop and inform a job description, particularly if the CHW role is new to an agency. Help to educate individuals, whether it's inside your agency or outside your agency with community partners who may not be aware of who community health workers are and what they do. And also in your agency to think about so that you can ensure that the full range of the scope of practice is included in the CHW position. So CHW skills, as we've mentioned, inform the development of CHW training and education, and they also help to ensure that standards and policy for training include the full range of skills, and that funding for training also covers the full range of skills. And CHW qualities can be really helpful in guiding your recruitment and hiring of CHWs. And also that you ensure that your own agency employment policies emphasize and promote the qualities and access to the profession for people who are trusted members of the community. At this point, it's my great pleasure to introduce you our presenters from the field. We have Amalia Amy Zamat, who's the Director of Prevention at the McGregor Clinic in Fort Myers, Florida, and also Stephanie Kennedy, who's the Supervisor of Health Education at CrescentCare, which is an FQHC in New Orleans, Louisiana. Welcome, Amy and Stephanie.
Thanks for having us, Allison.
Great. So this part of the webinar, we're really going to talk about implementation topics. And after each implementation topic, Amy and Stephanie will be sharing their experiences and observations and reflections that they experienced in their particular agencies. So one of the first aspects of implementing community health worker program is planning and preparing for the program. Important topics in this category are identifying the CHW role. So why exactly are you bringing this role into your agency? What are the goals of the CHW program? Will the CHW work with a particular population in your agency? Will they fill, or what gaps in services will they fill? And how will they fit into your workflow? How will they fit into your service delivery model? Another key aspect of planning and preparation is looking for and pursuing and obtaining buy-in from internally from the agency and externally from community partners. So now I'll turn it over to Amy and Stephanie, and they can share with you their experiences around this topic area. Amy?
Well, good afternoon, everybody. I will start by saying that for McGregor Clinic, this part was a little bit easier for us because I myself am a community health worker and have been doing community health work without that title for many years. And so when I sat with my Chief Executive Officer, we kind of had an idea of what the roles were. We were very familiar with the Core Consensus Project and what the roles were there. And so it really involved discussing it with key clinic leadership. So we met at the supervisors meetings and were able to cross different departments and talk about what were the needs, how everyone saw the role kind of fitting. And that way we ensured that there were no overlaps of services. Case managers understood their role that would be different from community health workers, same for the nursing department, adherence nurses, et cetera. And so because we had those discussions and they were ongoing, and at every point we were very transparent in our desire for this project and our desire for what the community health worker would be working on, the stakeholder buy-in came in organically from those discussions. And so we were very, very comfortable with the planning and preparation piece because of our previous familiarity.
And I'll say at CrescentCare, similar discussions. So we had to bring in everyone from the table just to kind of talk across the board. So we knew that we would be talking to medical staff, we'd be talking to case management, we'd be talking to people in operations, we'd be talking to people in finance. And what we really had to do was learn how to speak different languages. And what I mean by that is if you're pitching this to get buy-in from stakeholders and the medical staff, then we want to talk about how utilizing community health workers can increase clients coming into the clinic. So less missed appointments. If we're talking about case managers, if we're pitching to them, we really want to tell them, okay, this is how we can supplement your case management work. So case managers are often working with clients as they come in, but it's really difficult for case managers to go out because of their caseload and find the clients who have missed appointments or who have barriers to care. So if you're talking to someone in finance, trying to get them to buy into this program, finance wants to hear about, hey, what is this going to do? If we're going to implement this program, we're going to pay for salaries, how is this going to benefit the clinic? And if you have a community health worker who's bringing clients into the clinic, then you have more clients bringing in revenue, and then it's more revenue for the clinic. If we're talking to someone in operations, they want to know about logistics. Where is this person going to sit? What do we have to do to onboard them? So it was really important for us to pitch to different people and learn how to speak different languages in order to get that buy-in across the board. And also, like Amy said, we definitely had to work with different people to avoid overlap. So when we launched this program, we had just had 2 other community health work initiatives that started. So we have a test and treat program here. So clients who test positive for HIV, they're linked to care and started on medication within 72 hours. So we had a community health work program that was dedicated just to working with those clients. And then we also had another community health work program that was dedicated to our New Orleans East and Gentilly neighborhoods. And those 2 neighborhoods historically have had limited access to medical care. So we wanted to make sure that our community health work program didn't overlap with those other services. So our community health worker really was focused on working with clients who were already established in care and who might have fallen out of care. So we had to bring everyone to the table to get buy-in and to make sure there wasn't any overlap.
Thanks so much. So as you're planning, one of the things that you want to consider in your agency is setting up your program systems and infrastructure. And Stephanie, you alluded to this really nicely in your comment about working with and meeting with operations. So some considerations for systems and infrastructure that are needed to support the CHW role include, a plan for supervision, and something as simple as office space. Where is this person going to sit? Who are they going to be co-located with, if that's an important consideration? What is their access to the EMR or the electronic health record going to be? And how is that process going to work? And what will be their orientation to community partners? So at this point, I'll throw it back to Amy and Stephanie so they can share with you their experiences and lessons learned around systems and infrastructure that they built for their CHW program.
So for McGregor Clinic, it was really important for us to house the CHW within the prevention team as opposed to the medical or case management departments. And this was very strategic, one, because our prevention team is very flexible in our schedule just by the nature of prevention work in general. But the other piece of that is part of our prevention team is the outreach, it's the testing, it's the community partnerships, it's the flexibility to really be able to get out and get to know the community and get to know the resources that are available in the community to be able to meet the needs of the clients that go beyond their medical and case management needs. And so for us, that was the key thing, to place that person in prevention. And then, of course, we worked hand in hand with our medical side to ensure access to our EMR system in order to facilitate ongoing communication with medical, with case management, of course, apart from face-to-face communication, which happened regularly. And to do that, we made sure that our community health worker was part of various meetings, such as case conferences with case managers, with community partners, such as our housing opportunities for people with AIDS partners, our AIDS drug assistance program partners, other individuals in the community where our community health worker would have opportunities to interact to establish not just, a name or a phone number where we would refer people, but to really connect with partners who were specific in agencies that would then be a bridge to link patients to the services that they needed beyond just those things that are typically provided through case management and or medical referrals. Now, proximity was really important to us as well. And so with proximity, originally we were all in the same building. There was no distance. You could just walk over to somebody's office. Now, since then, we have moved to another building, but we're literally right around the corner, still in walking distance, so still very close. But moving to the new building allows us to kind of help remove some of the stigma, because when individuals are coming to access community health work systems and programs, they go beyond the typical medical building. And so the person's coming to a space that isn't considered that HIV building or the HIV clinic. So they're coming to more of a safe space, which helps the CHW kind of enhance the rapport that they've already built with our clients.
And so in CrescentCare, we did it just a little bit different. So our CHW was housed in our client services department, and it was very close in proximity to our clinic, our medical staff, case management, and any sort of ancillary support staff that we might have needed to contact in order to serve the client. So we thought it was better because the population that our CHW was working with were people who had fallen out of care. So they were already established in care. They might have missed a few appointments. They might have had some barriers that we identified that made them vulnerable to falling out of care. So since they already had relationships with case managers and providers, we thought it would be easier to house the CHW in the client services department so that she would have easier access to medical staff, case management staff. If we got the client back into the clinic, and we determined that housing was a barrier for them. Transportation was a barrier for them. Our transportation and housing departments are both housed in the client services department. So the communication was a lot easier housing our CHW there. Also, it made it easier for warm handoffs. So if we got somebody back in the clinic who hadn't been there for a while, the CHW could meet them in the waiting room, meet them in the exam room, and it made it better for warm handoffs. We also made sure the CHW had access to the EMR, so that made for easy communication between the case managers, the nurses, the medical providers. So it worked out better for us to house them in client services so they can have access to all of the ancillary and support staff on the client's care team.
Great, thank you so much. So at this point, maybe you've done your program planning and you're getting in place the systems and infrastructure. So you're thinking about recruiting for the role of CHW, recruiting, hiring, and thinking about staff development. So what happens after the hiring process? So this is a time where you can really think about the CHW skills and qualities that we visited earlier. Where you're going to do your recruiting for someone from the community. Special considerations for hiring someone who's a patient of the agency, as well as the difference between hiring someone who's a person with HIV versus someone who is not a person with HIV. And Amy and Stephanie can both speak to that. And then creating, having a plan for job retention. Community health work is particularly stressful work. A lot of community health workers work with the very highest level acuity patients. So having a plan for that, and also a plan for professional development, because this is a real workforce, and they should be paid like the professionals that they are. So Amy and Stephanie, what are your lessons learned around recruiting and hiring and job retention?
Yes, I personally, I love this topic, but given the culture of Southwest Florida, we determined early on that we didn't necessarily need a person living with HIV. We had a peer navigator prior to this project, and while he was very effective with individuals who sort of fit his demographic, it was really hard for individuals who were outside of his demographic really to relate to him, despite the fact that they all had in common this diagnosis. And so we really wanted to get someone who would relate on a different level, who could really cross some lines in terms of more people relating to the community health worker because of the scope of their work. And so what we did was we focused more on qualities and not so much on the skills. To be honest, we felt like skills can be taught. You can train anybody to have the skills that you need based on the C3, but the qualities needed to be intrinsic in the person. And so we focused on finding somebody who had the capacity to kind of handle the intense work that it takes to become a CHW, who had an idea of professionalism, who had an idea of just passion and really dedicating themselves to the needs of the patients and really understanding boundaries and barriers and working within systems. So that's where we focused our energy, and we were very fortunate to find this community health worker we found. And then as far as training, we really, initially the plan was just to provide the basic training, but then we realized, this person needs something more intense. And so we really focused on utilizing what Boston University provided. We utilized online trainings, a lot of in-person trainings. We provided trainings for the entire staff that were also relevant to the community health work. So like mental health first aid, trauma-informed care, motivational interviewing, all of those types of training. And then professional development is part of the culture of McGregor Clinic in general, which really assists with staff retention overall. But for the community health worker, I really feel like this is key. Allison, you mentioned paying them an appropriate salary, and I cannot echo that enough. These are not your bottom line workers. They're doing intense work that goes into biopsychosocial needs of patients that often medical staff and even case management staff don't have the time to do. And so professional development for us is critical. We do a lot of leadership training, a lot of development training, a lot of really training on understanding your own traumas and how you work around or through those traumas to be able to best serve your clients. So this recruitment and development piece is really, really important at McGregor, and it's really entrenched in our DNA.
And Amy, I couldn't agree with you more. Those qualities are super important. And I mean, for people who are starting out, who are thinking about implementing a CHW program at their agency or their clinic, these core competencies, they're going to be your best friend. I mean, it tells you how to implement a CHW program from start to finish. Before you even hire the CHW, you should know what you're looking for. And those qualities, being a self-starter, being motivated, a person who's going to go out and get the clients, who's relatable to the community, all of those things are super important. Now for our CHW, we didn't have a stipulation as far as whether they were a person living with HIV or not, but it just so happened that the person we hired was a woman living with HIV, but that wasn't a deal breaker for us. It wasn't something that we mandated when we were implementing this program. But I can speak from a recent experience and kind of to echo what Amy was saying. I'm not sure if anyone went to the United States Conference on AIDS last week, but a major theme that came up at that conference was about professional development. So community health workers are not your, like Amy said, bottom line workers. They're not disposable. You have to treat them like you would treat any other staff. So building them, pouring into them with trainings. We don't want to bring in people, give them stipends, pay them low wages, and then it's almost like people are discarded after that. And we definitely didn't want to do that with our CHW. And I would encourage people to really take heed to that, because this work is not easy. This work can be burdensome, and especially as a CHW who was also living with HIV and serving clients who are living with HIV, we don't know what triggers that might have for the CHW. So I know Amy mentioned trauma-informed care, but like we're talking about trauma that could be relived by the CHW as well. So really building them, pouring into them, making sure that they have a path to success and to leadership sometimes is going to be really important. So we thought that was key when we implemented our CHW program. And one other thing that I wanted to point out too was that when we're hiring CHWs, especially if you do decide to hire someone with a lived experience, sometimes we prioritize that over other things. So we didn't require a college degree or any sort of training for our CHWs. So be prepared to maybe teach your CHW about organizational skills, time management, workplace norms, things that other people may bring to the table that CHWs necessarily haven't had that experience in before.
Yeah, Stephanie, I have to definitely agree and echo that. I have several degrees, so I do value education, but I think that it's really important to understand that a community health worker doesn't have to have letters behind their name or specific degrees or specific titles. I think getting somebody who has those core values, those qualities that are intrinsic in them, and they have the capacity to learn the skills and all of the professional trainings that you can provide, I think all of that is much more valuable and gives you a community health worker who really is going to take your program to the next level.
Absolutely.
Thank you all so much. That really is an important topic. So shifting to after the hiring, process has happened, talking about orientation and training. So orientation and training for community health workers, probably is fairly similar to orientation and training in the agency for many other types of staff. But there could also be some unique needs of community health workers, particularly around contact lists and resource lists for community resources that they need, that access to is important for their work. Considerations about shadowing and training in terms of, is the CHW going to shadow other people at the agency? And also, are other people in the agency going to be shadowing the CHW? We learned in this initiative that that was a strategy that could be very effective in order to help members of the care team understand the community health worker's role and try to mitigate or work with redundancy of services. How are you going to get the community health worker access to the EHR? And also, if you're in a state that provides a certification for community health workers, considerations around getting your CHW certified. So Amy and Stephanie, if you can speak a little bit to your lessons learned and what you did in your agencies around orienting the CHW once they were hired.
Absolutely. So for McGregor Clinic, we already have an internal, very intensive onboarding process. We take the first 3 weeks when somebody's hired, and we actually arrange for them to shadow across all departments. They spend some time with each department getting to know what they do and how they do it. And we're very intentional about doing that because you cannot help a client navigate a system that you're unfamiliar with. So it's really important that all staff, not just our community health worker, but especially our community health worker, really understands clinic flow and the flow of getting a patient in the clinic and beginning their care and their treatment and understanding how that crosses over into case management and all those things. And then within the prevention department, we have continuing onboarding that we do where we include additional trainings beyond that. So trainings on how to do outreach, how to do group facilitation, classroom management, HIV counseling and testing training through our partnership with the health department, leadership training. This is in addition to subject matter trainings like those that I mentioned prior. And so all of that is already within our DNA, it's already in our culture, and it's really important that community health workers be included in that process. And I would say even have more intensive one-on-one types of trainings or smaller group trainings that really allow for some role playing so that the community health worker really kind of knows ahead of time, here are some things I may face, here are some challenges I may need to deal with, and I need to be prepared to do that. And allowing our CHW to be part of our prevention team even allowed for community engagement types of bridge building. So our community health worker attends our work, goes and does outreach at our soup kitchen, and she attends our health services information network meetings, and she is just constantly out there. She has built a strong partnership with the VA clinic because of the orientation that we gave her that said, you have the green light to really get to know not just McGregor Clinic, but the community at large that we serve. And then part of the other thing is really, again, validating the community health worker experience. So Florida has a coalition, the Community Health Workers Coalition, that actually is really pushing, endorsing certification for community health workers. And I've got to say, again, because of those qualities, my community health worker has taken the initiative. She is actually part of that coalition. She has spoken on panels for that coalition. And she and I are currently working on Florida certification as community health workers. Because again, I have a strong belief that we need to validate the community health worker experience. We need to really make it just as valid as perhaps, CNA positions, LPN positions. The community health worker has a place in the healthcare system. And those of us who are utilizing them now really need to take them to that next step where they become more than just a name, more than just a title, but a valid part of our health system.
And at CrescentCare, I think for our CHW program, we kind of had one leg up because our CHW was already employed with the agency, but she served in a peer support capacity. So she had already gone through all of the agency trainings, all of the onboarding. She was already familiar with clinic flow, like Amy mentioned. That's super important because, again, you cannot help a client navigate the system if you yourself don't know how to navigate that system. So she was already aware of all of the services we offer and was already pretty connected to the community and what resources the community had available. But again, we sent her to mental health first aid training, suicide prevention. There was motivational interviewing training, trauma-informed care. Our police department in New Orleans offers something called crisis prevention interventions. So we know that sometimes clients do have a lot of barriers. They have other things going on. Life happens to a lot of people, and it definitely happens to our clients. So they can bring that in with them into the clinic. So we made sure that the CHW was prepared to handle those situations as they arise. And one thing that I learned, and I would kind of throw this out there, is just expect to have to identify trainings on the spot. I mean, we often have situations come up that maybe we hadn't experienced before because community health work was new to our clinic. So based on current experiences that we were having, we determined, okay, well, maybe we should do this training or that training. So expect things to come up because this work is unpredictable. And one other thing that Amy was mentioning about the certification, so Louisiana does not have a CHW certification either. But one thing that our CHW participated in, internally, we worked with the Office of Health Policy, and we created a quality improvement strategy to identify gaps in retention. So we utilize the CHW program. We set certain parameters and metrics and use that to pitch to the Office of Health Policy that, hey, you know, the CHW is bringing clients in. These clients who are coming in are virally suppressed. So we showed how the CHW can improve retention, viral suppression, and help the client decrease those barriers to care. So our hope was that the Office of Health Policy from that quality improvement project would see that community health work, we should develop a certification for it, and we should write it into our Ryan White standards of care.
Thanks so much. At this point, we have a little time, so I wanted to ask Stephanie and Amy your thoughts about a question that we have from an attendee. Jonathan's asking, what is the difference between community health workers and peer navigators? He manages a project in Texas, and they're implementing a case management peer navigation model of care. So what are your thoughts about the differences between CHWs and peer navigators?
So this is Amy. I'll answer that for us. As I mentioned before, we had a peer navigator, and while the scope of work was similar, we were challenged because what we found was that being HIV positive was not enough of a connection to other patients to really help them relate to the peer navigator so that he could be effective doing what he needed to do. For us, the CHW, the key for that person is community. They are part of the community, both because they were relating as far as geographically, that's where they live, they know the area, they know the people, they tend to run in the same circles. And so what we found was that broadened the scope of the connection to the patients. Each of them were able to build a rapport with our CHW based on different facets of that community piece. As far as the work, for us, the way we set up our peer navigator program, it mirrored how we set up the community health worker program. So this was still someone working with biopsychosocial needs, things that go beyond the scope of case management line items and Ryan White line items, and really focused on what is important to the patient. What do they need? What is it that is happening in their life that has nothing to do with HIV care, perhaps even nothing to do with medical care, but those are the issues and the factors that are affecting their care along the continuum. So for us, the work was the same, but how the person related to the community that we were trying to serve ended up being completely different when we looked at peer versus non-peer.
And at CrescentCare, I would say, so our community health worker was formerly a person who did peer support. And I wouldn't necessarily call it peer navigation, but I also want to throw out too that community health work can look different at different agencies. So a community health worker can be sort of a peer navigator. They can be a client educator. So it really depends on how you implement the community health work intervention at your agency or clinic. But for us, like Amy said, community was definitely a addition to the peer support role. And a person living with HIV or not, you can still act as a community health worker. So I think the peer designation is one key thing that will differentiate them. But as far as the work goes, the community aspect of it is definitely going to be very different. But again, that could look different in your clinic. It depends on how you decide to implement that role.
Thank you very much. Yeah, so just to emphasize the points that Amy and Stephanie made, community health workers right now is, as a workforce, really considered to be an umbrella term. Everyone who's working as a community health worker definitely does not have the job title of community health worker. Peer navigators definitely fall under that umbrella of community health worker. And if you go back to the CHW roles that we looked at, peer navigation is absolutely one of those roles. Sometimes the community health worker complete scope of practice can be slightly broader. So I would say peer navigators are CHWs. And in your program, one thing you can do is look at the roles to see if you're really using the peer navigator and the model that you're creating in the most effective way possible to fill the gaps that you're seeing. Thanks for that question. So let's switch gears a little bit and talk about, in terms of implementation, what actually happens between the CHW and the client. So what is the program criteria? Which patient population, if there is a specific patient population that the CHW is going to be seeing, it's important to have a process for referrals. What is that? How does that integrate into your existing workflow and systems of services? And what is the actual service delivery model? And here again, where is a place where you can keep the CHW roles in mind. So if your CHW is, limited to navigation, maybe you also want to consider then if they are doing any capacity building or any kind of outreach. Is the CHW integrated into care plans if you use care plans? And two big questions we've dealt with a lot on this initiative is, what is the caseload size of the community health worker? And also, what is the plan for transitioning clients? When does that happen? How does that happen? Is the client involved in the transitioning process? And to what extent? So now I'll invite Amy and Stephanie to share their reflections and the lessons they've learned around client engagement and participation.
Absolutely. So at McGregor Clinic, initially when we started this project, the community health worker really was tasked with dealing with what I will call the most challenging clients, the highest acuity type of clients. These were the clients that perhaps case managers, adherence nurses, maybe the nursing staff, and even the physicians themselves were sort of at a standstill. The person may have been in care, but really was disengaged, perhaps wasn't virally suppressed, and really couldn't understand why, because medically they were meeting all the criteria. And so these were the initial people referred to the client. And all of our referrals, both then and now, come internally through our EMR system. And so it was really about our community health worker really building rapport and building relationship with those clients to really understand and hopefully kind of break down some walls as to what was affecting their care. And as I mentioned before, it was really about issues that had nothing to do with medical care at all. For example, one patient really needed, what he intrinsically needed was connection and validation from his veterans experience. And so that took a while to establish. We had another patient who really, it turned out he had cognitive issues, and we kind of knew, but hadn't really put our finger on it until he elaborated and began to talk. So these were things that, again, take time, take delicacy, take skill to be able to get through. But what we learned was, in reality, all of our patients could benefit from having a community health worker kind of help them navigate through those goals and desires that they have that perhaps are not related to anything medical, but do affect their medical care. And I'm talking about even off the wall, you know, if a client really is depressed and it turns out the root of their depression is because their dog doesn't have a cage for them to transport and they happen to be homeless and it's presenting an issue, my community health worker will go so far as to call different places to find where we can get a pet cage to be able to meet that need so that the person can then turn around and focus on their medical care. So it's those types of things that I'm referring to as those biopsychosocial that go beyond medical and nursing. And so after some time with implementation, we decided to refocus our CHW to kind of meet the needs of all of our newly diagnosed and all new patients to the clinic. And so we've revamped, we've set up a new system. So anybody who's entering McGregor Clinic for the first time is going to engage with their community health worker. Our community health worker is now fully integrated into the patient flow. So it happens automatically. It's not a request. It's just something that's going to happen just like they come in and have labs. They come in and they see their community health worker. She works on them with simulated type of care plans. Really, it's more goal-oriented, goal-driven. And so where before we really didn't have a transition plan because of the types of patients we dealt with, now the idea is every patient is going to have a CHW for 6 months, and then they will kind of get a warm handoff into case management, if applicable, so that they continue to have somebody kind of holding their hand and helping them navigate this system, which we know can be a bit daunting.
And I just kind of want to echo Amy's situation at McGregor, that what we thought worked when we initially implemented the CHW program is not necessarily how the CHW program ended up running throughout the course of it. And I think the biggest lesson learned was that retention and linkage and navigation doesn't just happen within the four walls of the clinic. It's not just about medical appointments. Like Amy was saying, it could go beyond those things, beyond things that we think about. So initially our CHW was just kind of calling people, making sure they were on top of their appointments, meeting them in the clinic. Occasionally she would do a home visit if she was able to go out to the house with a case manager or a nurse. But there were some other things that clients needed. So we integrated our CHW into our Life Skills Series program that we have. So that was for clients living with HIV and not, but it was specifically to talk about life skills that people need in order just to survive. I mean, the basic things that we think about, like learning how to use a cell phone. I mean, things that we take for granted, a lot of people don't know how to do that. And if a client knew how to utilize technology, they could access their patient portal to get their labs. They could get an app on the phone to remind them to take their medications. So just like the things that we take for granted, the things that we think are pretty menial are big in retention. So we definitely incorporated her into that program, and she was able to make more connections with clients and then connect with them outside of the clinic. So we thought that that was something that was really important. It's not just about your medical appointments. It's not just about your medications. It's about all of these other things that are going on. And one thing that I admire about the implementation at the McGregor Clinic is that they nestled the community health worker in the prevention department, because it's in different departments, it's almost like a cultural difference sometimes. So in client services, we're more clinical. We do operate mostly in the clinic, but in prevention, oftentimes you're working in non-traditional hours. You're out in the community more than you're in the office. A lot of our prevention staff don't even have offices because they don't need them. They're constantly on the go. They're constantly tabling at events. They're constantly doing venue-based testing and outreach. So I do take that away from this project, and I appreciate working on the Boston project because we got a chance to see how other clinics implemented at their respective sites, and definitely putting the CHW closer in prevention. I know that there's value in having them close to the clinic, but for the cultural reasons, having them closely tied with prevention, I think is super important because it gets you in that mindset that, again, retention and linkage is not going to happen in the four walls of the clinic, and it's not going to happen 9 to 5 or 8:30 to 4. So I do like that about the implementation at McGregor.
Yeah, and Stephanie, I got to tell you, I know we're not talking about data in this webinar, but what we found was that having our CHW be part of prevention, be out with us on the mobile unit doing testing, when people were first diagnosed, the fact that she was able to meet right there with them and connect with them, we have 100% return rate on people that we test. They're coming for care. The few that don't choose us, because it's patient choice, they can go wherever they like, she still connects with them and makes sure that they're linked to care. So we're talking about utilizing CHWs to improve linkage. I mean, there's no arguing. It does it. It works. And not only that, but research has shown that if you have a connection to a clinic in a tangible way that goes beyond just, labs and doctor visit bills, you have a higher chance of staying in care. And really, that's what this is all about. That's why we're all in this. We really want to make an impact on that continuum of care for every single patient.
Yeah, and then just to keep in mind, so to anyone who is interested in implementing a CHW program, the reason why we didn't put the CHW in prevention is because, so I mentioned earlier in the presentation that we had 2 other CHW initiatives that we had recently implemented around the same time as the Boston project. And we had 2, maybe 3 community health workers who were designated to work solely with the people who were newly diagnosed. So they had those warm handoffs, and they were able to make it to the clinic. And we are definitely, like you mentioned, Amy, we're definitely seeing higher rates of linkage to care, retention in care, and viral suppression in those clients. So it really depends on how you decide to implement the CHW project at your agency. So if you are looking for the CHW to work with newly diagnosed people, then yes, put them in prevention, have them do testing so they can be out in the community and they can already have the connection with the client if they do test positive. And like I said, that's why we decided to put the Boston University community health worker in the client services department, because she was working with people who are already establishing care. But that prevention culture is just so important. And I think that, I guess what in the future, what we could work on is trying to find a balance. How do we find a balance with that prevention culture that we're looking for? And then also having the CHW work in client services or in the clinic. I think that's something to consider. And it wasn't easy, but we can definitely think about how to find a balance in the future.
Thank you both so much. Yeah, community health workers are often characterized as bridges, and they bridge, communities and healthcare systems. And it made me think of that because it seems like in your agencies, they're also in some ways bridging the community and the healthcare system in terms of bridging the prevention part of your agencies and the clinical part of your agencies. So, so there are a lot of different things to consider. So the last topic in terms of implementation that we're going to talk about is something that ended up being really, really key in our experience in this initiative, and that is supervising community health workers. I think we were all a little surprised at the amount of time that community health workers really required, and the amount of supervision required, especially at the beginning of implementation of programs. So we want to spend a little bit more time on this topic than maybe we have on other topics. We want to highlight 3 types of supervision that we utilized in this initiative, and those are administrative supervision, supportive supervision, and clinical supervision. And administrative and supervision really are usually delivered by the person who is the administrative supervisor. And in this project, we sort of had a takeaway where we decided that one way to characterize the administrative supervisor is that that person is the community health worker for the community health worker. And so kind of what that means is they are the person who is assessing the performance and giving feedback. They are the person who's teaching skills to CHWs. They are the person who is directing the work administratively and managing other staff that they might also be supervising, because in our experience on this project, the supervisors were supervising a great number of staff in addition to community health workers. But the supervisor is also the coach, also providing some mentorship and leadership modeling to the CHW. They are the CHW's advocate. They turned out to be a really key individual in the success of the integration of the community health worker into the care team. And they're also a major collaborator in the relationship of the CHW to the agency and to community partners. So that was something that surprised us a little bit, and we really do take away from this initiative that the CHW supervisor is a really key person, key player, and requires a really special kind of person, just as CHWs have their own unique qualities. The other type of supervision we want to highlight is clinical supervision. So by clinical supervision, we don't necessarily mean HIV providers or doctors and nurses. Clinical supervision specifically provides space for community health workers to explore how their work with clients can produce reactions for themselves, but also for their clients. And also is important for CHWs to have a space to talk about maintaining healthy boundaries. Boundaries is really something that's key in the relationship between community health workers and clients. So having a space to talk with a professional about maintaining healthy boundaries. Boundaries can be especially important if the CHW is a patient of the agency, for example. Clinical supervision should absolutely be provided by a licensed clinician, for example, a licensed clinical social worker, licensed mental health counselor, or other behavioral health provider, and it should be provided on a regular basis. And that looks different in different agencies, but those are the key takeaways for us on this initiative. So for this last topic, Amy and Stephanie, what are the lessons that you've learned as a CHW supervisor during this process?
So for McGregor Clinic, we are probably not a good example of that model because we didn't follow that. And it's not because we didn't intend to. We had people sort of assigned to those positions, but the reality was because of the skills that I brought to the table, I actually played the role of all three of those types of supervisors. Apart from my day job, I am also a trained minister, and within that training comes mental health counseling training. So I had the unique perspective that I could provide all three of those at the same time. And any other supervision provided was more for the medical record training, using the electronic system, TA, that type of thing. But one of the things that was key for our supervision model was our open door policy. And it really is something that we have throughout the agency. It's not just in my department. But because we have an open door policy, anytime my community health worker had an issue, whether it be a client issue, whether it be an administrative type of issue, or even a personal issue that would affect how and how well she could do her job, the open door policy allowed for open communication, dialogue. We used, scientific techniques that are used in counseling to be able to work through some issues. We just had open dialogue. And so as we were building our own rapport and our own trust, it really allowed for an environment of growth and development of my community health worker, to the point where my community health worker at the very beginning of this project, in year one, was a little quieter, a little more reserved. Now she is fully launched. She is a leader. She is out there empowering others. She's educating others. And I'm not taking credit for that, but what I'm saying is that the supervisory model that is recommended from this project and that we've learned from this project really has value. The other thing I think that's important that we established was, okay, there's HR things and documentation things that have to be done and paperwork type of things, but really having ongoing check-ins, how are you? How are you doing? How was your time with that client? If I knew she had a difficult client that she was going to be working with that day or that afternoon, how did it go? What did you do? How did you handle it? Not specific client data information, but how do you feel? What's the pulse at this moment? Where's your mindset at this moment? Because finishing with one client means, okay, I'm getting ready to work with the next one. And so a lot of that administrative, supportive, and clinical pieces really overlapped. And the fact that I held all three of those meant she always had somebody to go to at all times for all those needs.
So in one of my previous conversations with Amy, I told her that she's the supervisor. I've never seen somebody act in all three capacities. I'm not sure how she pulled that off, but kudos to you, Amy. But I was the administrative supervisor on this project. So I really focused on paperwork, documentation, any training needs that the CHW needed. We did case consultation. So specific cases that came up, the CHW would come to me and we would talk through it. We would determine, okay, this is your course of action. This is the person you need to contact. We really worked through cases in our either weekly or monthly check-ins. So we checked in individually on a weekly basis, but on a monthly basis, we had team meetings. And there we would plan activities. We would plan for our life skills group. We would talk about logistics. We would talk about ideas for further integrating the CHW into the clinic flow. So we had two different outlets on an administrative level for supervision. On a clinical level, we had an LCSW who just so happens to be the PI on this project, and she offered monthly clinical supervision to the CHW. And one thing that I wanted to make sure is that whoever provided the clinical supervision also understood the work of a community health worker. So it would have been easy to find a therapist, a social worker, anyone in the agency who could provide this for our CHW, but to understand the work that the CHW does, to understand the thought and how much of themselves they put into the job, the clinical supervisor needed to understand that in order to approach supervising a CHW in the correct way. So lucky for us, we were able to have a clinical supervisor who understood all of that and to stress the importance of self-care. So like I mentioned before in the presentation, that clients bring themselves into the clinics. We also, in this work, we bring ourselves into our jobs. And sometimes that can be burdensome. Sometimes that can be tiresome. Burnout is absolutely real. So self-care is absolutely important. And we made sure that in clinical supervision and in administrative supervision, we stress the importance of self-care. And not only for the CHW, but for the CHW supervisors too. Allison mentioned that the supervisors can be the CHW to the CHW. So if we're providing all of this clinical support to the CHW, we also have to make sure that we're taking care of the supervisors and taking care of ourselves as well.
Yeah, and I think that self-care piece is important to our retention and professional development as well, because you don't want to bring on staff that's strong and passionate and really staying on board, and then you get burnt out and you're walking out the door and they're looking to you to be an anchor and you can't handle it anymore. So I think self-care really is important on all levels.
Right, and sometimes as supervisors, we know that our staff looks to us But I don't think that sometimes our staff understands, okay, we're holding you down, we're supporting you, we're making sure that, you have everything you need as your supervisor. But sometimes we don't have anybody holding us down.
Exactly.
So we have to really make sure that we're taking care of ourselves to be that anchor, like Amy said, because people are looking to us. And that type of kind of burnout and feelings, that can trickle down to your staff. So we really have to make sure that even if somebody else is not holding us down, if we don't have that type of support from our supervisors, that we can take care of ourselves to make sure that we're bringing our best selves to the job and supervising our CHWs and ultimately impacting the clients.
That's great stuff. Thank you so much, Amy and Stephanie, for all those observations and reflections on what you've learned.
Yeah, at this time, we'd like to thank our partners and colleagues for their help and support. So we'd like to thank Brian Fitzsimmons, our HRSA HAB project officer. We'd also like to thank our project sites that really worked with us over the course of the years and helped us to collect data on their programs. The 1917 Clinic of the University of Alabama, Birmingham, the East Carolina University, Franklin Primary Health Center, McGregor Clinic, Southern Nevada Health District, CrescentCare, Beth Israel Hospital Family Treatment Center, the Jacques Initiative, Legacy Community Health Center Incorporated, and Southwest Louisiana AIDS Council. We'd also like to thank the many trainers and facilitators that are far too many to name that supported this initiative along the way, as well as our amazing advisory group.
Thanks, Linda. And now we're going to spend some time repeating your questions and hopefully answering them and having a little bit of discussion as best we can. As I mentioned before, for those questions we don't have time to answer during the webinar, we will answer them offline, and we will plan to send out a written question and answer document that'll be posted along with the recording from the webinar today, as well as the webinar slides. So the webinar slides will be posted on Target HIV, as well as the Center for Innovation in Social Work and Health and the CHW Initiative project page. And we'll also be posting the webinar recording when it's available, and then a little bit later on, the written question and answer document. So my colleague Rebecca, as I mentioned, has been fielding your questions and answering some that we were able to answer. I think we'll start with a question that was touched upon, but maybe Amy and Stephanie, if you can talk about it a little bit more. Someone was asking about the impact that you feel that CHWs have had on, specifically on linkage and retention in your agency. So if you already said a little bit about it, but if there's more that you have to say.
So this is Stephanie from CrescentCare, and I think that CHWs play a huge role in linkage and retention and care. So like we mentioned before, that again, CHW is an umbrella term, so they could be called different things at your agency, but especially with retention, some of the work that the CHW does, like it could be, if the person is a person living with HIV, they could be in a peer support role, they could be facilitating groups, they could be doing life skills like our CHW did, they could be attending appointments with clients, that hand-holding throughout the process, throughout the linkage and retention process, attending appointments. We know that clients who participate in support groups typically remain engaged in care and usually achieve viral suppression and remain virally suppressed. So having a CHW who can facilitate those type of activities is going to be really important in linkage and retention and care. But like I mentioned, the person cannot be called a CHW at your agency. They could be called a peer support specialist, a peer navigator. It could be an educator. But the work is what we're talking about. So those activities are going to be really crucial in making sure your clients are engaged in care.
Yeah, and from McGregor Clinic, I did want to make a distinction. So when I'm talking linkage, I'm talking about linkage of our clients, so people who are HIV positive, to the services that they need beyond basically the walls of our institution. which is different from linking individuals who have been lost to care. And for our agency, that's not something we focus on because we have a strong partnership with the Department of Health, and they actually have both a linkage specialist and an ARTIS, which is antiretroviral treatment access study workers who utilize that intervention to reach those who are lost to care. And when they bring them back to our facility for care, if they choose to come to our facility or return to our facility, that's when the community health worker becomes that linked piece for the person who was brought back by our partners. So I did want to make that distinction. However, I agree with Stephanie 1,000%. I think that community health workers play a vital role both in linkage and especially retention. As I said, there's research documented that, if individuals can be linked mentally, emotionally, socially to their medical provider, not just I have an appointment, I have to be there, I have an appointment card. Studies show that they will be long-term dedicated to their care. And so that's why we really want our community health worker symbolically or metaphorically touching the life of every person who comes through our doors.
Thank you so much for that. So Mary asked a question about the number of CHWs you have compared to your overall patient population. What are your thoughts about that?
So I want to say at CrescentCare, we had 6 CHWs who were all working on different projects. We just had one CHW on this Boston initiative that was working with clients who were establishing care, but who either had barriers or who had fallen out of care. The caseload wasn't that high for our community health worker, but I think that there was a bigger need than one person. And I'm just saying that because, like we talked about before, it's not just about necessarily attending appointments with clients. It's not necessarily about the work that happens in the clinic, but it would have been helpful to have more people to do the outreach work, to do some of the other ancillary things that might have needed to get done in order to serve the client. But as far as compared to our whole agency and all of the clients who might have needed access to some CHW service, we had, I want to say 6. I think it was 6. And we just made it work. And like I said, we split up the demographics. We split up the people who were newly diagnosed. We split up people who lived in a certain neighborhood. Our CHW took the people who are already established in care. So we made it work. But I think that particularly on this Boston project, it would have been helpful to have more than one CHW just to do some different things.
And for us, we only have the one community health worker. And underneath the Boston project, although not all of the individuals consented to be part of the research, my CHW was working with approximately 15 individuals at the time. And if you recall, I did say they were high intensity, high acuity. Mm-hmm. Since we shifted our model, because now she sees all newly diagnosed and new to the clinic, what we've determined is that we're going to put a cap of 40 individuals max. So that would be her maximum caseload, but they're at different acuity levels. And what we did was we came up with our own acuity scale, sort of mirrored to what the Ryan White case managers use, but not as intense, of course. And so that is determining. So we determine no more than 10 in each acuity level. With a total of 4 acuity levels, with 4 being the highest acuity, more intensive care, 1 being the least. And then again, we did come up with a plan where no patient would be working with her no more than 6 months. And at that point, they should be well entrenched into the system and tied to a case manager who hopefully at that time has built rapport with them as well. And we also have other staff members. McGregor Clinic has an amazing care model. So we have an adherence nurse, and we have other supportive staff. We have 10 nurses, we have 10 case managers, we have multiple providers. So there are multiple systems within our clinic to be able to catch those individuals that perhaps won't be a good fit for the community health worker, but it is our desire and our intent that the community health worker work with as many as possible over time.
And I was going to add that too, Amy, that it really will depend on the clinic too. So our clinic had case management. We have peer support staff. We have linkage and retention folks. We have the other CHWs. So for other clinics or agencies who might not have all of those supportive services, it may be a possibility that your CHW might have a larger caseload, or more people will be reaching out to your CHW. And I want to say the maximum that was recommended was maybe 20 or 25 to have on a caseload, because usually the people who are going over to the CHW are the people who need the most challenging clients. But, you know, luckily we didn't have an issue with a lot of people on the caseload, but it depends on the agency. So if you don't have a lot of those other supportive services like case management or navigators, then you might see your CHW's caseload growing, and that's something that you'll probably just need to manage.
Thank you very much. Letitia has a question about CHWs working with newly diagnosed patients. She's wondering if you think there are any key questions that a CHW could ask of a new diagnosis patient to get a sense for what the barriers to care for that person are.
So this is Amy. I'm going to tell you what my community health worker does, because she's really good at it. So when she meets them and she talks to them and says, you know, I'm not a medical person, I'm part of the team, I'm here to help you through the issues that are important to you. And then she goes straight into, you know, what's important to you? If we don't have to talk about your HIV, if we don't have to talk about your medical care, what is something you want to work on? What is important to you? What are some things that you think I need to know to be able to help you work through this? This is new for you. What are some things that I need to be able to provide you with? And so she kind of goes in that direction, really letting the patient know that you have resources to ask the medical questions. You have resources to ask the nursing questions, but you need to know that you have a safe space where you can discuss all the other issues. You know, for a lot of our patients, they want to know about dating. They want to know about disclosure. They want to know about, they're not asking you about medication because the doctor already said that, but they want to know, what are all these other things in my blood work that have nothing to do with CD4 and viral load? What does it mean when you tell me, you know, I can access a food pantry or closed closet? What are the criteria? What does that mean? How often can I do that? And so when she begins to talk about those things, again, that are non-medical, non-case management related, it immediately creates a rapport. So that's what my community health worker does.
And I would say that it's going to be key for your community health worker to be skilled in motivational interviewing. So like Amy was saying, taking care of the whole person is going to be really important. And in addition to that, community health worker has to have the skills in order to pull that information from them. So making sure they're asking open-ended questions, making sure they're letting the client talk, making sure they're doing active listening. All of that's going to be important. So in addition to taking care of the whole person, we have to make sure that the community health worker has the skills to draw out that information from the client.
Thank you so much. That's a challenging question, I think. Melissa's asking a question about re-engaging clients who've fallen out of care, and she's wondering what the criteria you have in your agency is for having fallen out of care. So how long does it have to have been since the patient came in before you consider them out of care?
So we had the criteria of they had missed an appointment or they hadn't been seen by a provider in 6 months or more. And we considered changing that criteria at some point because there's a possibility that the client was right at the 6 month mark and maybe they rescheduled. But we really looked at the 6 month mark as far as determining whether the client was considered out of care or not. And that's just, it has to do with our agency protocol. So usually the provider will see clients for a provider visit every 6 months and have them come in for labs every 6 months. So, I mean, that could have been a case management appointment, that could have been a provider appointment, that could have been a lab appointment. But we wanted to see if they had something scheduled, had they been seen in 6 months. And if they hadn't, and we were able to run lists in our EMR, and we were able to determine the clients who fell into that criteria. And then we would do a little bit of research in the EMR as well. So we would go in and we can see everything is categorized, like if a client showed up for their appointment, if they were seen and checked out, if they no-showed, if the clinic canceled, if the client canceled. So the EMR was really important to be well versed in, so the CHW can navigate her way around and see what really happened. So if a client had a case management lab or provider appointment that was scheduled and they missed it, she can go in and see, okay, but this person rescheduled, or this person didn't need to be seen, or they did something over the telephone with their case manager. So having her be able to navigate the system in the EMR was really important to kind of weed through the people who came up on the list who maybe didn't need to fall into that criteria of falling out of care.
Yeah, and I would say for us, it's ditto on all of that, except for the additional piece where we will actually send that over to, once we figure that out, we send that over to the health department, and they have linkage staff that actually go out and seek these people out and hopefully find them, determine their barriers, help address those barriers, and bring them back into care, where again, which is where our CHW picks up.
Great, thanks so much. So a question that's come up a couple of times is really the million-dollar question right now in community health work, and that is how to fund community health worker positions. So I want to take a moment to say a couple words, and then I'll let you and Amy, I think this might be our last question of the webinar, talk a little bit about how you're doing it in your clinic. For the most part, in general, community health worker positions are still usually funded by grants. It's changing a little bit. It started changing with the Affordable Care Act, which was also a really big driver for the community health worker workforce. Cecil, I hope I'm pronouncing your name right, Cecil Tenga, made a note that in Connecticut, they are taking on CHW billing, specifically for around Medicaid. So being able to bill Medicaid for CHW services. Take a look at the question and answer for the link. There's a NASDAD protocol that might help in your local jurisdiction that you can look at. We'll also include that link as part of the question and answer document that we'll post. You want to talk to your Ryan White project officer, depending on what Ryan White parts you receive. There is a possibility that you could fund CHW services under Ryan White, but I'll open it up now for Amy and Stephanie to sort of share whatever they are able to share about how their funding worked. I'll also, actually, if I could also just add, as part of the initiative, Boston University funded about half of the salary of the community health worker for the project period. Now that the project period is over, the sites sort of have their own strategies for sustainability.
So all of our CHWs at CrescentCare were funded on grants. All of the grants ended at the same time, August 31st of this past month, but we were able to tap into Ryan White Part D, like you mentioned, Allison, to fund some of our community health workers, depending on the demographic that they were working with. So we know Part D is for women, infants, and children. So that community health worker was doing a lot of work with youth, so we were able to tap into Part D for that. And like I mentioned before, something that we're working on is pitching to our Office of Health Policy to see if we can get community health work written in as a standard in our Ryan White Part A funding so that it could be a billable service. And I think it's really important that they write that in. And I think a lot of knowing the role of a community health worker for a lot of people is going to be crucial because when we initially pitched our Office of Health Policy and we explained, what the community health worker was doing, they thought that this was something that fell under case management, or the case manager should be going out and finding these people who are out of care. And we had to explain to them, case managers already have a huge caseload and they're working with clients who are constantly coming into the clinic, like they're dealing with active cases. So for the clients who have fallen out of care, they don't have time or the capacity to really find clients, to find these cases. So we had to explain the role of the CHW, how the CHW could supplement case management and other ancillary services, and really pitch and show them the value of having community health work written into the Ryan White standard. We're not there yet, but it's something that we're working on. We definitely need a sustainable model so that CHWs can be recognized and funded through things other than grants. And
I would say the same for us. So we actually are a subcontractee for an HIV prevention grant through High Impact Prevention. And so that brings us some funding. And then we're also a 501c3 not-for-profit. So we do have a director of development who handles philanthropic activities, donations, smaller grants, like we get grants through Broadway Cares and we get grants through the Campbell Foundation, so places like that. And so because a lot of those will provide us with unrestricted funds or undesignated funds, we are able to kind of shift that around and utilize some of that to cover salary. But again, this is why I only have one community health worker. I would love to have 2 or 3. I would love to have different languages represented in my workforce. But unfortunately, just like with CrescentCare, you know, we've got to come up with plans and come up with mechanisms to be able to raise the funds. One of the impetuses for me specifically wanting to get this position certified is so that we can create a billable model as opposed to just doing this on our own, but really being able to build different funding streams to be able to validate that service. So again, these are all parts of the sustainability plan, but for now, we're trucking forward with what we have.
Oh, sir, at the end of the webinar, you'll receive a short survey. We're grateful for your feedback on today's presentation. Thanks again for joining the webinar. The webinar is now ending. Have a great day.